Thank you.
Okay. Okay. Thank you. Thank you, ma. Good afternoon, ladies and gentlemen, colleagues, teachers, senior consultants. We welcome you all to today's webinar. We are happy to have you. Today, we'll be having Today we'll be having our 6th session of our 6th webinar series. And we're going to have 2 topics for presentation. The first will be an assessment of airway for ease of intubation, while the second will be airway equipment practical considerations. At this juncture, I would want to welcome the moderator for today, Dr. Agwu Nnanna, and I would like to hand over the floor to him for him to continue with the rest of the introduction, and then we'll commence. Thank you. Dr. Agwu, please.
All right. Thank you, and good evening, everyone. I hope I'm audible enough.
Yes, you're audible. Please commence.
Thank you to the Education Committee for giving me this privilege to moderate today's meeting. Special thanks to the NSA President, and good evening to our senior consultants and other colleagues who are here for this discussion today. Today, we are privileged to have 2 topics which will be presented by 2 of our colleagues. The first topic is on assessment of airway for ease of intubation. I need to be presented by Dr. Tobola Olatunde, who is a senior registrar in the Department of Anesthesia, Lagos State University Teaching Hospital, Ikeja, Lagos. He will be speaking to us for about 35 minutes. And then the second topic, which is on airway equipment, practical considerations, will be taken by Dr. Ibrahim Salim Abdullahi, who is an honorable consultant anesthetist at the Abubakar Tafawa Balewa University Teaching Hospital, College of Medical Sciences, Bauchi State. And he also is the secretary of the Society of Specialists in Airway Management in Nigeria. So we will have these 2 presentations. Afterwards, we will now take the questions at the end of the presentation. The first presentation will be for about 35 minutes, while the second presentation will be about 40 minutes. Thereafter, we'll take questions and then answers. So at this point in time, I want to introduce the first speaker, Dr. Olatunde Tobola, to please take the floor for his presentation. Thank you. Dr. Olatunde, you have the floor, please.
Good afternoon, teachers, very senior anesthetists, senior colleagues. I am Dr. Olatunde Tobola, a senior registrar in anesthesia LASU. This afternoon, I shall be taking airway assessment, ease of intubation. I'll be going through this with the following outline. I'll introduce the topic. We shall go through predicting a difficult airway. We shall go through airway assessment tools. Then I will conclude. I want to crave the indulgence of the audience. Airway assessment is a wide topic. I will sometimes have to gloss over some details on the screen. Thank you. About 30% of anesthetic deaths are associated with problematic airway management. Poor planning will subsequently lead to suboptimal management in these patients with difficult airway. And this has led to most of these tragedies. The entire incidence of difficult endotracheal intubation in the surgical population is about 5.8%, but this could be as high as 22.2% in patients with obstructive sleep apnea. Development of airway emergencies increase the probability of death and brain damage by 15-fold. So what are the goals of endotracheal intubation? It is to ensure the airway patency for oxygenation and ventilation. It is to protect the lower airway from gastric contents, blood, and debris. Tracheal intubation often requires direct laryngoscopy. It could also be achieved by indirect techniques or advanced equipment. Direct laryngoscopy requires a line of sight from the upper teeth to the glottis. Also requires mouth opening, extension of the upper C-spine, displacing of the mandibular arch tissues. The challenge of achieving tracheal intubation is a spectrum that spans from relative ease to difficulty. The relative ease of intubation is directly related to the difficulty that is encountered during the process of intubation. The effectiveness of mass ventilation during pre-oxygenation affects the duration of apnea during tracheal intubation and thus the ease of intubation. Therefore, we could say that the relative ease of intubation is inversely related to the difficulty of the airway. So the more difficult the airway is, the less ease it is to intubate that patient. And the more easy it is to intubate the patient, the less difficulty in the airway that would be encountered. Additionally, the use of airway assessment to predict difficult airway is fundamental to achieving the ease of intubation. The American Society of Anesthesiologists defines difficult airway as a clinical situation in which a conventionally trained anesthesiologist experiences difficulty with face mask ventilation of the upper airway, difficulty with tracheal intubation, or both. The Canadian Airway Focus Group takes a broader definition, and it is where an experienced provider anticipates or encounters difficulty with any or all of face mask ventilation, direct or indirect laryngoscopy, tracheal intubation, supraglottic device use, or surgical airway. Langston and Kunitz also defined an intubation as difficult if a practicing anesthesiologist needed more than 3 attempts or more than 10 minutes for a successful endotracheal intubation. Difficult intubation is the most important cause of anesthesia-related morbidity and mortality. Its etiology may be operator-based, patient-based, or equipment-based. Airway assessment, on the other hand, are processes that detect risks to the airway maintenance, ventilation and oxygenation, not just difficulty in laryngoscopy or intubation. These processes, by way of history examination and investigations, will help produce an airway plan. The airway plan will anticipate and circumvent predicted difficult airway, or alleviate their adverse effects. So airway assessments will help us develop an airway plan. And having an airway plan will ease our intubation. Let's look at how we can predict a difficult airway. Predicting a difficult airway is best done before surgery during the pre-anesthetic review, taking relevant clinical history, physical examination, and appropriate investigations where they are necessary. Patients needs to be clerked. Patients' records needs to be looked into. Anesthetic charts need to be reviewed. Patient needs to be evaluated for his desaturation risk. Some history that would suggest that would be predictive of difficult airway includes, but not extensive, edentulous patients, bearded patients, neonates and infants, patients with contractures from burns, congenital anomalies, acquired difficulties like pregnancy, obesity, diabetes mellitus, rheumatoid arthritis, ankylosing spondylitis, osteoarthritis, acromegaly, snoring, obstructive sleep apnea, in which we might have to use our stop bang questionnaire, severe tetanus, large goiters, oropharyngeal tumors. Some iatrogenic problems may be previous C-spine surgery, which the vertebra has been fused, which will limit extension of the neck, oropharyngeal radiotherapy, maxillofacial procedures requiring wiring of the jaw, previous laryngeal, tracheal, or temporomandibular joint surgery. History of trauma, maxillofacial trauma, mandibular, laryngeal, tracheal, patients that suffered head injury and need cervical stabilization with or without a fracture. Other relevant history in emergency patients, we know in some scenarios in which we have limited time to do a thorough airway assessment. We should find out the starvation status or fasting status of these patients. Aspiration risk should be sought after. It is increased in difficult airway. Might not necessarily, it doesn't predict difficult airway, but it is increased in difficult airway and may complicate any airway management situation and should be an essential part of our airway assessment. The patient's last oral intake, patient's comorbidities, medication and current pathology that may lead to the patient's increased risk of aspiration should be considered. Where possible before surgery, ensure reduction of gastric pH and volume by fasting, pharmacological means, and mechanical decompression with the gastric tube. Other congenital anomalies associated with difficult airway are shown in this table. Some of these congenital anomalies have craniofacial deformities that contribute to contribute to difficult airway, like mid-phase hypoplasia, maxillary or mandibular hypoplasia, micrognathia, glottosis, macroglossia, and also cervical instability. I have pictures of a few of these congenital anomalies. In the Treasure Collins, we can see the obviously receded chin. In Down syndrome, they have abnormally large tongues and ospitoatlantoaxial instability. In P. they also have a receded chin and a large tongue in this. Klippel-Feil syndrome has this distinguishing feature of abnormal fusion of two or more of the cervical vertebrae. This causes them to have a short neck and a decreased range of motion in the head and neck area. The Beckwith-Wiedemann syndrome have abnormally large tongues. The hydrocephalus, the size of the head relative to the body makes the anesthetist unable to achieve that plane from the upper part of the teeth to the glottis. Maxillofacial trauma, as shown on the screen, you can see the normal anatomy is completely obliterated in this picture and will pose difficulty to the anesthetist. Large neck tumors will displace the normal anatomy of the airway and make the airway difficult. Would like to look at physical examination now and look at some things we need to look out for when we're examining our patients. Some hairstyles that prevent neck extension, especially those on the plane of the neck extension. Anatomical hindrances like choanal patency, small mouth, receding chin, high arched palate, cleft palate, full neck, large breasts, acquired difficulties, burns, like I mentioned before, tumors and hematomas of the airway, restrictive scars that limit mouth opening and neck extension. And like I also mentioned before, with a BMI of greater than 35 kilograms per meter square, you have some associated difficult airway. Poor C-spine movements, poor dentition, prayer sign, which is indicative of diabetes mellitus. Also, we need to note if the patient has any surgical equipment like a neck collar or halo traction that will prevent intubation or mass ventilation. We need to palpate the neck swellings if the larynx and trachea have been displaced. Before surgery, we need to identify the cricothyroid membrane in case we need to do a cricothyroidotomy. This can be done. If it is impalpable, it can be located by ultrasound and marked. It's a picture. These are pictures showing some of the hairstyles that could impede the neck extension and create a situation of a difficult intubation or difficult direct laryngoscopy. In the pediatric age group, we should be wary when the weight is less than 10 kg and when the patient has a small chin. Investigations that could be done, which come in when it is necessary. An indirect laryngoscopy, a video laryngoscopy. At this view, this gives us a view of the larynx, and the views of the larynx can be classified. These classifications can tell us, can help us anticipate a difficult airway. Other investigations, X-rays of the chest, thoracic inlet, cervical spine. We can get a magnetic resonance image or a computed tomography of the chest for complex airway and soft tissue pathology. And a endoscopy can be done to assess the patency of the choana. Let's look at airway assessment tools. So predictors of difficult mask ventilation include age greater than 60 years, male sex, a full beard, a BMI greater than 35 kilograms per meter square, previous difficult tracheal intubation, snoring, obstructive sleep apnea, a dentulous patient, a thyromental distance less than 6 centimeters, malampathy classes 3 and 4, facial abnormalities, neck radiotherapy, and a diff mask score of equal to or greater than 5. These 13 criteria were used to categorize face mask ventilation as easy, difficult when face mask ventilation is inadequate, unstable, or requiring 2 providers with or without neuromuscular blocking agents. It is classified as impossible when face mask ventilation we are unable to face mask ventilate with or without neuromuscular blocking agents. Let's look at the diff mask score. The diff mask score uses 10 predictors of difficult mask ventilation, and the score ranges from 0 to 18. A score of equal to or less than 5 connotes relative ease. A score of 6 to 10 would require further assessments by other different methods or investigations. Higher scores predict increased risk and difficulty. The score has a sensitivity of 85% and a specificity of 59%. Let's take a look at some predictors of difficult direct laryngoscopy. The first we'll be taking is the interincisor gap, which is the distance between the incisors and the alveolar margins with the mouth opened maximally and should be at least 3 centimeters. The patient's 3 fingers could be used to assess this, or the examiner's 3 fingers, or the patient's 3 fingers can be used to assess this interincisor gap. 3 fingers would amount to about 6 centimeters. However, a distance of less than 3 centimeters predicts difficulties, and a distance less than 2.5 centimeters would make superior supraglottic airway insertion to be difficult. Thyromental distance, or the Patel's test. This is the distance between the tip of the thyroid cartilage to the tip of the mandible with the neck fully extended. The normal distance is greater than or equal to 6. Less than 6 predicts about 75% of difficult laryngoscopies. Combining the Patel and the malampathy test increases specificity but decreases sensitivity. The Sava test, also called the stenomental distance, is the distance between the sternal notch to the tip of the mandible, neck fully extended, mouth closed. It should be equal to or greater than 12.5 cm. Less than 12.5 cm is associated with difficulty with a positive predictive value of 82%. The next slide shows a picture of both the thyromental distance and the stenomental distance. Let's look at mandibular protrusion. It can be classified into 3 classes, A, B, C. B and C are associated with difficulty. Let's look at the upper lip bite test. Upper lip bite test The patient attempts to bite as far up their lip as possible. It is categorized into 3 classes. The first class, where the incisors bite the upper lip and the upper lip mucosa is not visible. Class 2 is where the lower incisors bite the upper, but the upper lip mucosa is partially visible. Class 3 is where the lower incisors fail to bite the upper lip. Class 3 is a strong predictor of difficult laryngoscopy. Extension of the upper cervical spine. When this is restricted, it increases the risk of difficult direct laryngoscopy. The movement can be assessed by flexing the head on the neck and restraining the lower C-spine with a hand on the neck. That is, restraining the C-spine with a hand on the neck, on the back of the neck, then fully extending the head. We can place a pointer to allow estimation of the angle of movement, but objectively, you place 2 fingers on the head, one on the patient's chin and one on the occipital protuberance, and extend the head maximally. With normal C-spine flexibility, the finger on the chin is higher than that on the occiput. When the fingers are at the same level, it's indicative of moderate limitation. When the finger on the chin is lower than the finger on the occiput, it indicates severe limitation. The next slide is a pictorial description of what I just explained. The next is the modified Mallampati test. The examiner is positioned directly opposite the patient. The oropharynx is viewed while the patient opens his mouth maximally, protruding his tongue without phonating. Classes 1 and 2 are indicative of a relative ease of intubation. Classes 3 and 4 views are associated with difficult laryngoscopy. These are the pictures of what we are supposed to see in the 3 classes, and it makes uses of views of the forces, the fossal pillars, the uvula, the soft palate, and the hard palate. Let's look at laryngeal view. I have 2 pictures here. One is a diagram, and the other is what you would see in when an anesthetist does direct, laryngoscopy. This is what you would expect to see. That's the picture on the right. So this laryngeal view could be classified with the Cormack and Lehan's classification. It has 4 grades of views. Grade 1, the has a full view of the glottis. Grade 2 has a partial view of the glottis or the arytenoids. Grade 3, only the epiglottis is visible. Grade 4, neither the glottis nor epiglottis is visualized. Grades 3 and 4 are associated with difficulty. In the Cook's modification of the laryngeal view, you have 6 grades in this classification, and these grades can be divided into the easy, the restricted, and the difficult classes. And the easy views require no adjuncts. The restricted views require a bougie, and the difficult views require advanced techniques to facilitate intubation. This is a more like a live view of the Cook's modification. The Wilson score consists of 5 factors: the patient's weight, upper C-spine mobility, jaw movement, a receding mandible, and protruding upper teeth. Each factor is scored 0, 1, or 2, from broadly normal to severely abnormal. A total score of greater than 2 predicts about 75% of difficult intubations and has 12% of false positives. The Machoka score detects critically ill patients at risk of difficult intubation. It has a range of 0 to 12, and a score of greater than 2 predicts difficult intubation. The Machoka score, is like an aide-memoire. The M stands for malampathy, A stands for apnea, C stands for C-spine. The O in mouth opening is what is used in this score. C stands for coma. H in severe hypoxia is where the H is used, and that's all these have 1 point. And the non-anesthetic intubator also has 1 point. The Lemon Airway assessment score for difficult intubation in the emergency department. So this score combines both our examination and all the other airway assessment scores, like the inspection, you look, then evaluation consists of the interincisor gap, the hyomental distance, and the thyromental distance. Then the malampathy, then obstruction of any kind, and the neck mobility. It has a total score of 10. The higher the score is, the more the patient is at risk of difficult intubation. A multi-center Cochrane review of bedside tests for predicting difficult airway using 133 studies and 844,206 participants by Roth et al. Was published in 2019, concluded that for difficult direct laryngoscopy, the average sensitivity ranged from 22% for mouth opening to 63% for upper lip bite test. The average specificity, however, ranged from 80% for modified malampathy test to 95% for the Wilson risk score. The upper lip bite test had the highest sensitivity of all tests considered. For difficult intubation, the average sensitivity ranged from 24% for thyromental distance to 51% for modified malampathy test. And the average specificity ranged from 87% for modified malampathy to 93% for mouth opening test. The modified malampathy test had the highest sensitivity of all tests considered. So this table is a summary of the meta-analysis for the screening of. The table shows the meta-analysis of screening tests for identified difficult intubation. And these were the other scores that were assessed and their sensitivities and specificities. Let's look at predictors of difficult awake tracheal intubation. With an experienced operator, the complication of unexpected removal of a fiber optic bronchoscope, video laryngoscope, or tracheal tube during awake tracheal intubation is about 1 to 2%. Predictors include inadequate oxygenation, an uncooperative patient, operator and or assistant inexperience, suboptimal environments, airway blood or unmanageable secretions, inadequate topical anesthesia, oversedation, and very narrow airway. Predictors of difficult front of neck access include obesity, anterior neck masses, infection or scarring, tracheal deviation, previous radiotherapy, surgical collar or external fixator limiting access. Let's look at the pediatric age group. For the predictors of difficult mask ventilation, the age is important. The risk increases as the age decreases. Neck circumference is important. Having a receding chin and poor neck extension is a predictor of difficult mask ventilation in the pediatric age group. For difficult intubation, it is associated with weight less than 10 kg, with micrognathia, and with more than 2 direct laryngoscopy attempts before an indirect technique is used. The practical use of airway assessment. The 4th National Audit Project looking at major complications of airway management in the United Kingdom highlighted significant deficiency in airway assessment as a factor in many of the cases of airway complications. Out of 133 reports, difficulty in airway management was anticipated in 66 cases, but subsequent management strategies was not always matched to the initial assessment. Guidelines for the management of anticipated and unanticipated difficulty with mask ventilation and tracheal intubation exists. For these guidelines to be viable, they rely on the assumption that each of these options is a credible proposition in the first place. When problems are detected in the primary airway assessment, this should prompt the possibility of an alternative individualized airway management plan. For example, if a patient with a severely restricted mouth opening develops an airway complication on induction of anesthesia, the use of a supraglottic airway device, although recommended in the guideline, is not actually a feasible rescue strategy because it would not be possible to introduce this device into the mouth. So mortality and morbidity cases for airway difficulties should be presented regularly at clinical meetings and used to test the recommendations of established guidelines. And local guidelines may be required to fit into our environment, especially where where the resources are not available to procure advanced high technology airway equipment. In conclusion, preoperative identification of potential difficult airway is critical to the ease of tracheal intubation. An airway assessment is incomplete without appropriate history, physical examination, and relevant investigations when necessary. Achieving a relative ease in tracheal intubation alleviates significant morbidity or possible mortality. My references are shown on the screen. Thank you for listening. I'm happy to take your comments and your questions.
Okay, thank you,
Thank
Dr.
you, everyone.
Towobola Olatunde, for that wonderful presentation. I think we will note our questions so that at the end of the second presentation, those who have questions, you can either raise up your hands, we'll recognize you and you ask your questions, or you put down your questions on the chat box so that the questions will be answered at the end of the second presentation. So I think we'll go ahead to take the second presentation by Dr. Ibrahim Salim Abdullahi. Thereafter, we will now go to the question and answer session. Dr. Abdullahi, you can go ahead. Thank you.
Thank you, the moderator. Well, good evening, my teachers, my mentors, and the entire anesthesia family. My topic of presentation, as earlier introduced by the moderator, is airway equipment practical considerations. That is my name, and then the center I work with on the screen. So I intend to take the presentation based on this outline as before you on the screen. So by way of introduction, airway equipment are devices used to improve or maintain patency of the upper airway and to facilitate delivery of oxygen or anesthetic gases and removal of carbon dioxide to and from the lungs. So by this, airway equipment are integral component of airway management. That is when we consider the airway management as a broad term used to describe tools, techniques, and procedures used to support and control oxygenation and ventilation, as well as delivery of anesthetics. So, but however, the focus of this presentation is on the tools, which are the equipment used in airway management. So airway management remains a cornerstone of our anesthesia practice. And the primary aims of airway management are to 1, ensure airway patency, 2, ensure oxygenation and ventilation of the lungs, and 3, to protect the lower airway. So to achieve this, there are a variety of equipment that can be used to support a patient's airway. So what is required from the provider is familiarization with available equipment at his disposal, and which is the key to a successful outcome. So we should cause in an emergency situation, we can only do what we can and not what we cannot. So we should show enthusiasm in learning skills that we think we will never use, because these skills will one day be the savior to one's life. So there are different approaches used in airway management, and then for each approach, there are equipment are used. So these approaches are 1, face mask ventilation with or without adjuncts, 2, airway clearance, 3, supraglottic airway device use, 4, tracheal access above the vocal cords, that is endotracheal intubation, and then 5, tracheal access below the vocal cords, which is also referred to as surgical airway, which can be in the form of cricothyroidotomy or the tracheostomy. So in all these approaches, airway equipment are used because there are plenty airway equipment which we cannot exhaustively discuss in this short presentation. So I intend to discuss the airway equipment that can be used to achieve each of these approaches. So these approaches, again, may be used alone or in sequence, and there is sometimes an overlap. where the use, for example, a supraglottic airway device can be used for intubation, in which case, for example, intubating LME. And the intubating LMA can be, the LMA can be used as a sole means of maintaining the airway, but again, through the LMA, the airway can be intubated. So the first one is the face mask. The face mask, one of the advantages is that it brings the anesthetist into closest and continual contact with the patient. And then optimal positioning of the patient's head and neck and keeping mask seal is needed. So we need to maintain a patent airway so that the intended gases will be delivered to the patient's lung. So a good fit should avoid pressure on the eyes and then seal without excessive pressure. So we should, as much as possible, avoid using excessive pressure on the face mask over and on the patient's face. And then the use of transparent masks help to detect cyanosis, condensation of moisture, secretions, and vomitors. And then this will allow the provider to suction in case of the secretion or vomitors. And then where there is cyanosis, if detected, then it means there is either the gases are not delivered because of obstruction, and then that will alert the provider to act on time. So the consideration in the use of face masks, especially for the pediatric patients, is advocated to use a low dead space. An example of that is the Rendell-Becker, but however, the Rendell-Becker, they are not transparent, so secretions and vomiters cannot be seen by the provider. And then, if possible, this face mask should be flavored either with a vanilla or strawberry, depending on the child's favorite flavor. And then some of the masks, as seen on this picture, they can be cartoonized and then the child's cartoon character, so that it will enhance acceptance. And then, of course, in the elderly patients, there is a difficulty in achieving a seal because of the carving, the loss of teeth, so difficulty to achieve a tight seal. So sometimes one needs to even to use a gauze to fill in the area of leakage, or to make a bone of gauze and put it in the cheeks, so that it will help to achieve a tight seal. The indications for the use of face masks is one, pre-oxygenation. Two, it can be used to maintain for the maintenance of anesthesia, especially for short duration anesthetic. And then the patient, there is no risk of aspiration. Or it can be used as a bridge to definitive airway. Maybe at the end of the procedure, patient is extubated deep, and then the face mask can be used to deliver oxygen while maintaining an open airway. The contraindications are full stomach, facial trauma, and unstable C-spine injury. Because to effectively use the face mask, there is a need we do airway maneuvers so as to open the airway. So the complications could be hypoventilation, where the patient is inadequately ventilating, or hyperventilation in the case of positive pressure ventilation. And then with positive pressure ventilation, of course, there is gastric insufflation and then gastric distension, which further predispose the patient to regurgitation and aspiration. So the agents that can be used with the face masks are the oropharyngeal airway, and the indication is for airway obstruction. So because for obvious reasons, we know that in the unconscious patients, the commonest cause of airway obstruction is the tongue falling back. So however, that can be prevented with the oropharyngeal airway in situ, and then it facilitates max ventilation, and also facilitate suctioning, because a suction catheter can be passed through the oropharyngeal airway to suction the hypopharynx. Relative on contraindications are intact gag reflex. because it will stimulate vomiting and then aspiration because the airway is not protected. Then complications include dental damage, soft tissue damage, bleeding, or lingual nerve palsy. Proper sizing is the watchword in the use of oropharyngeal airway, and to determine the appropriate size, it should be from the flange that is from the flange at the angle of the mouth to the earlobe. That's the appropriate size of the patient. And there are different sizes available for adults and children. And then there are other varieties of the oropharyngeal airway, like the Barman airway, and then the Oversapien airway. And the advantages of this can be used with fiber optic bronchoscope, which we shall see later. Another adjunct that can be used with the face mask is the nasopharyngeal airway. And the indications are just like the indications for the use of oropharyngeal airway. However, this is better tolerated even in the conscious patient. However, the relative contraindications are basal fracture of the skull or patients with coagulopathy, and the complications are bleeding, soft tissue damage, and of course also the watchword here is the proper sizing, and the sizing is from the nostril to the earlobe. So the second approach of airway management is the airway clearance. And blood secretions or debris is clear with suction apparatus, and that will help to open the airway, and we achieve a patent airway. So oropharyngeal suction is usually done with a Yonker sucker, and this can have a side port to digitally control the flow. And with the side port that is usually proximal, where the sucker is connected to the suction tubing, there is a hole that when blocked with the finger, it presses the negative pressure that suctions what is intended to be suction. Softer tracheal catheters are also used and also for nasopharyngeal suction. So, but however, that's for the secretions, but for debris and foreign bodies in the airway, they can be removed with forceps, like our Magil forceps, and this can be done under direct laryngoscopy. And then suction can clear the airway and improve the breathing during laryngoscopy. Sometimes during laryngoscopy, it's obscure, secretions obscure the vision of the laryngos copper. So, however, with suction, it can improve the view. And these are examples of the suction catheters in use. These are the flexible ones. This can be used through the oropharyngeal airway and then the nasopharyngeal airway. But however, this Yonker suction is rigid, so it cannot be used through these airway adjuncts. Now, the next approach to airway management is supraglottic airway devices. These occupy the middle ground between the face mask ventilation and intubation regarding anatomy, security, and invasiveness. So they are intermediate between the face mask and then the tracheal intubation. And they are all inserted blindly. There are over 15 devices. Some are single use, and then there are some that are reusable. The indication is 1, to facilitate oxygenation and ventilation, 2, for delivery of anesthesia, and then of course they serve as a conduit for intubation, like the intubated laryngeal mask airway, or they can serve as a bridge to extubation, where the patient is extubated deep and then supraglottic device, especially like, for example, the hypertensive patients that you don't want to extubate awake, because allowing the endotracheal tube will stimulate pressor response, and then that will elevate the blood pressure. So you can do a bridge extubation, remove the endotracheal tube, and then pass an LMA to maintain oxygenation. And then it can serve as a rescue device in the during the failed intubation. The relative contraindications to the use of supraglottic airway devices are active gastroesophageal reflux disease, because they don't confer airway protection as they sit above the larynx, so they don't confer airway protection. And then in obese patients, because of the seal pressure is higher than the ventilating pressure. And then in patients with traumatic airway injury, the other category of patients require airway protection, or in patients with intestinal obstruction because they are at risk of regurgitation and aspiration, or in patients with intoxication or restricted mouth opening, because with restricted mouth opening, there is difficulty in passing the laryngeal max airway, or in patients with deformed airway anatomy. The complications of using the supraglottic airway devices include inadequate ventilation, airway injury, sore throat, tongue edema, frenulum injury. This one has also been documented in the literature, and then aspiration, because they don't protect the airway. So the supraglottic airway devices, they are classified as first generation, second generation, and in fact, there is even the third generation. The first generation are the LMA Classic and other manufacturers of laryngeal masks. They are simple and then low pressure, less than 20 centimeter of water. Of course, this one, they cannot, they are relatively contraindicated in the obese patient. And then they are easy to place. And like I said earlier, they are placed blindly. While the second generation include the iGel, LMA ProSeal, the LMA Supreme. These have additional design features. One, to reduce aspiration risks, because they have a gastric port through which gastric content can be suctioned with the suction catheter, and they allow for higher seal pressure to facilitate controlled ventilation. And this also can be used for the obese patient, and then they have an integrated bite block. So unlike the first generation, where when in situ you need to pass a bite block, this one, they have a bite block incorporated. And these are the varieties of the supraglottic airway devices. These are the first generation, example of the first generation. And then these are the second generation. On this side, we have the ProSeal, we have the airway, the air channel, and then of course there is this one that serves as the gastric channel, where gastric content can be suctioned, and the opening here at the tip opens at the upper esophageal sphincter. This is the iGel, also have the air channel, and then the gastric channel, which opens at the tip here. And then these are examples of the intubated laryngeal max airway. This is the only third generation supraglottic airway device, that is the Vasca mask. So an LMA, in use of LMA in the prone position. Review prone LMA insertions. There are studies that have shown that LMA has been used successfully in the patients in prone position. And successful LMA placement was achieved, 100% was achieved, and then a successful ventilation in 100%. So, but the study found that the risks are comparable to those when LMA are used in the spine patients. So LMA will also be used in patients in prone position. So what are the considerations for the use of supraglottic airway devices? One, the provider should know that they don't protect against aspiration and therefore don't provide a definitive airway. So they have to be used in the patient. There is an elective patient who has been fasted and doesn't have any risk of regurgitation and aspiration, and shouldn't be used in poor mouth opening, pharyngeal pathology, or obstruction at or below the larynx, because they sit above the larynx. So where there is obstruction, it means that the intended gases will not reach the lungs. And then the reusable devices cause transmission of infection. Therefore, we should ensure proper disinfection and then sterilization. Supraglottic airway devices are less invasive than the endotracheal tubes and are preferred in patients with history of upper respiratory tract infections, especially patients with history within the last 2 weeks. And then obstruction in children due to downfolding of the epiglottis. So sometimes you pass the device and you discover that the air is not delivered to the lungs, there is obstruction. So there is the need to remove it and then reinsert it again. So now the fourth approach to airway management is the tracheal access above the vocal cords. And the gold standard in this is endotracheal, the use of endotracheal tube. So it's considered the gold standard device that provides airway patency and protection. So it can provide the patency, oxygenation and ventilation, and it also protects the airway. So all the goals of the airway management can be achieved with the use of endotracheal tube. Most single-use tubes are polyvinyl chloride, and reusable tubes are silicone, and they can be cupped or uncupped tubes. Cupped or uncupped tubes are available. So depending on the patient age and then what is available. The cuff is inflated with air via a pilot balloon and a self-sealing valve. That is where the cuff is inflated. So the endotracheal tube are classified into cuffed and then the uncuffed. Usually the uncuffed are used for pediatric patients, which were recommended between the ages of up to 8 years, in some literatures, and then 10 years in some other literatures, that the uncuffed should be used. And then, however, recently, in fact, at present now, we see even all the tube sizes, they come with a cuff. Even the smallest size, that is size 2 millimeter, comes with a cuff. However, the cuff is the large volume, low pressure cuff. And then can also be classified into as kinkable versus the non-kinkable. The non-kinkable are the armored tube or the reinforced tube, which are mainly used for surgeries involving a shared airway, like ENT and then maxillofacial surgeries. And then it can be a single lumen or double lumen. Double lumen is usually used for lung isolation. And examples here we have the Robert Shaw, the left and the right double lumen tubes. And then of course we have the preformed, either the north facing or the south facing, which are used for ENT and then the maxillofacial procedures, where they carry the tube away, the breathing circuit is taken away from the patient from the surgical field. So these are the single lumen tube. This is the uncuffed, and then this is the cuffed, has a pilot balloon, and then this is the example of the double lumen tube. And then for the preformed, we have the south facing, which is usually for oral intubation, and then the north facing is mesotracheal intubation. And this one also can be cuffed and then uncuffed. So the indication for endotracheal intubation include general anesthesia or aspiration prevention, that is protection of the airway. In patient, this especially in the intensive care unit, patients with low GCS less than 8 is advocated to protect the airway, or can be used in patients with respiratory failure or inadequate oxygenation or ventilation, as for patients that can be placed on mechanical ventilation. And then it facilitates passage of a range of devices into the lungs, such as suction catheters, so tracheobronchial toileting, used in patients with aspiration pneumonitis, or the fiber optic bronchoscope can be passed for diagnostic or therapeutic purposes. And then this also can be used especially in the double lumen tubes. It can be used to check the correct positioning of the tube. And then bronchial blockers for lung isolation also can be used to pass a bronchial blocker where you don't have the double lumen tubes. So the complications of endotracheal intubation include sore throat, dental damage, dental damage usually from laryngoscopy, and then soft tissue damage when the intubation is traumatic, and then vocal cords damage also with traumatic intubation. So the considerations for the use of the endotracheal tubes include the endotracheal tube size in children greater than 2 is determined, greater than 2 years is determined by a formula. It is the internal diameter in millimeter is equal to h in years 1 over 4 plus 4. So the recommended tracheal tube size that's for children less than 2 years are 2 millimeter for premature, less than 1 kg, that's premature neonates, and then 2.5 millimeter for premature that is greater than 1 kg, and then 3 to 4.5 millimeter for term neonates and up to 2 years. The uncuffed endotracheal tubes were traditionally recommended for general anesthesia in children below the age 8 to 10 years age. The cuffed tubes were avoided in children for fear of damaging airway from an overinflated cuff. But however, like I said earlier, now the cuffs that are seen with the pediatric sizes tube are the high volume, low pressure cuff. So this fear is eliminated. However, with the cuff tube, there is reduced risk of aspiration and improved ventilation with less fresh gas flow and end-tidal carbon dioxide monitoring. Because for the uncuffed, of course, because there is a leak, peritubal leak, so there requires a higher fresh gas flow to adequately ventilate the child. So, however, to do endotracheal intubation, it requires laryngoscopy. So laryngoscopy refers to the process of visualizing the larynx, typically allowing visually guided tracheal intubation. So it can either be direct using a conventional laryngoscope like the Macintosh or the Miller's blades that we use, or it can be indirect using video laryngoscope or fiber optic intubation or intubating LME. So in general, 3 criteria are needed for success. 1, a view. So you have to see the vocal cords, and then alignment of the airway, and then space for tube passage. That is for the that is whether oral or tracheal or nasotracheal. Sorry. So the alignment, especially, yes, the alignment, because we have the oral axis, we have the pharyngeal axis, and then the laryngeal axis. So in positioning, they are positioning to align these axes in a single plane. So that will enhance the view of the vocal cords, and this is particularly when using the direct laryngoscopy, because you are trying to create a line of view from your eyes of the laryngoscoper to the larynx. So you are creating a view. So there are 3 limitations for all laryngoscopes. 1, when there is blood secretions, they obscure the view of the laryngoscoper. And then trismus. So the mouth must be able to open sufficiently to accommodate the blade of the laryngoscope, and of course the tube intended to be passed into the trachea. And 3, training, because effective use requires sufficient practice. So it's technical. One has to learn the skills to successfully perform the procedure. So for the direct laryngoscope, there are different types. The choice of laryngoscope depends on the patient's age and then the user preference. A view is achieved by transoral insertion of the blade, forming a line of sight between the intubator and the patient's larynx. So reusable blades can be washed, scrubbed, and autoclaved or gas sterilized. So we have different types of blades. Here on this, we have the Macintosh. They come in different sizes, size 1, 2, 3, and 4. for adults and pediatrics. And then we have the polio blade. We can see how an obtuse angle. This was initially designed for use during for the iron lungs, but however, it's now utilized in patients, obese patients, and then patients with large breasts. And then on this side, the F, we have the McCoy. The McCoy has a lever here, which when flexed, there is a hinge here. It enhances it improved laryngoscopic view. For example, where maybe the laryngoscopic view is Cormac and Lehan 3 or 4. So with the use of McCoy can improve the view to 2 or even less. And then we have the short handle blades, also used for patients, obese patients, and then patients with large breasts. And this is have the straight blades, that is the millers, which are particularly recommended for use in pediatric patients because of the size of their epiglottis. So there are aids for tracheal intubation, and they are typically used in situations where an airway may be challenging to intubate. So some of these aids include the bougies, gum elastic bougie, then the stillets. Bougies are atraumatic guides over which an endotracheal tube can be railroaded. So during laryngoscopy, instead of passing the tube, the bougie is passed and then the tube is railroaded over the bougie. Or then we have the stillets, which are firm, malleable devices that can alter shape and curvature of the endotracheal tube. So this is an example of a tube loaded with a stillet. Here is the stillet. So with the stillet in situ, one can alter the shape of the tube to facilitate easy intubation. And then the stillet should not be allowed to protrude beyond the tube orifice. So as we can see here, the stillet terminates somewhere around here. So it should not exit through the tube orifice because it can cause trauma to the airway. So now the transtracheal access, which is the fifth approach to airway management. And this is where we have cricothyroidotomy and then tracheostomy. So it is expected that every anesthesia professional should know how to do an emergency cricothyrotomy, and should the need arise. There are commercial kits available which can be used to achieve this. But where it is not available, there is a simple way we can make a cricothyrotomy set. Just get a 2 ml syringe, a size 16 cannula, and then the connector of a size 6 or 6.5 endotracheal tube. The connector, you remove the plunger of the 2 ml syringe, and then you put the connector, which can snugly fit into the barrel of the syringe, and then the syringe is connected to the cannula. So that can be used to deliver oxygen to the patient airway. So tracheostomy is done when airway patency or protection via the airway, upper airway, is not possible. A surgical approach is called open, which is carried out by the ENT surgeon. But however, percutaneous dilatational techniques are most often done within the critical care. So this can be done even by the anesthetist. Well, the cricothyroidotomy involves airway access through the cricothyroid membrane. So you need to identify the cricothyroid membrane, and then you puncture it with the size 16 cannula. Preferably, if the literature is described with the use of size 14. But in our own setting, the 16 that is readily available. And this is a temporary technique with conversion to another form of airway control advice, usually within a day or so. So because it is an emergency, so a definitive airway should be carried out as soon as possible. So the consideration, the small size of the cricothyroid membrane and capillary position of the infant's larynx makes airway access techniques impractical and dangerous in small children. So cannular cricothyrotomy sets are not available for children, and they are unsafe and are not recommended for use in children. So it is for use in the adult patient. So another, for the indirect laryngoscope, yes, we have the video laryngoscope. The video laryngoscope provide a non-line of sight view through a screen display. So instead of creating a line of sight between the intubator and the patient's larynx, where it is displayed on the screen. So video laryngoscope has made an impact in overall successful airway management, both in the operating room and as well as in the ICU. Especially the use of video laryngoscope was more advocated during the COVID era. And studies have found that video laryngoscope are associated with better glottic visualization, unlike the direct laryngoscope, and then they provide a higher success rate for difficult airways because the laryngoscopic view, they provide a view of 60 to 80 or 90 degrees, unlike the conventional laryngoscope that provides just around 15 degrees, and then has a faster learning curve, resulting in a higher success rate for intubation even by the novice physicians. So the video laryngoscope has undergone stage of evolution. They are classified into non-channeled and channeled. The channeled, they have a guide where the endotracheal tube is anchored, unlike the non-channeled, where you need a rigid stellate for a successful intubation. But in this one, in the channel, like the air tract and then the pentax, they have the channel where the tube is loaded. So it's just with the exposure of the glottis, the tube is manipulated into the trachea. No need for the use of stellate. Then another form of the indirect laryngoscope is the fiber optic bronchoscope. Fiber optic technology has been incorporated into airway equipment with huge potential to obtain good glottic visualization during laryngoscopy because of the capability to continuously visualize the airway. It provides suction and deliver oxygen or local anesthetic to the patient's airway in an awake situation or post-induction. And these are distinct advantages of the fiber optic bronchoscope. This versatile device is used for airway inspection, biopsy, toileting, and tracheal intubation by oral or nasal routes. This can be done awake using local anesthetic to anesthetize the upper airway, or asleep, that is a patient under general anesthesia. So the flexible fiber optic bronchoscope, however, is expensive, it's delicate, and it needs intense decontamination because that's for the reusable. However, now there are disposable scopes. Training is needed to master the skills of patient preparation and device use. And because these equipments are lacking in our training institutions, so the skills is not readily available. So the main limitations are image loss, which can occur because of blood or secretions, or inability of patients to tolerate an awake approach, or deficit in practitioner skill. So, but because it has a suction and then oxygenation channel, then the view can be improved. So inability of patients to tolerate an awake approach can be either from poor preparation of the airway or inadequate anesthesia of the airway. So the patient needs to be counseled, and then the nostril should be preferred, and then of course, anesthetize the upper airway using the lidocaine spray, or sometimes we can even use nebulization of lidocaine with adrenaline. But that improves it reduces bleeding, and then it numbs the airway. So these are examples of the fiber optic scope. This is the reusable one. This is black, and then this one is single use. So this one, the ambu type, it comes in two sizes, the adult and then the pediatric size. So, but this one is for, this one looks like an adult, this one is an adult size. So, in conclusion, there are a wide variety of airway equipment available, and when appropriately used, provide great margin of safety. Airway management requires safe, effective, and reliable equipment used to achieve two goals: provision of gas exchange and protection of the lungs from aspiration injury. Equipment must be available for both planned and unplanned events, and should be available at time of need and the practitioner able to use it. And this is, we should make it a habit that at the end of able patient assessment, airway assessment, we have a plan A, B, C. And with this, we will ensure that all equipments for the various plans are available, and we don't have to be running helter-skelter to get the equipment when the need arise. So we should choose the right equipment for the right patient. These are my references. Thank you.
Wow. Thank you, Dr. Ibrahim, for that wonderful presentation. We have listened to two presentations. The first one on the assessment of airway for ease of intubation, which was a loaded and powerful presentation. We have listened to the second presentation on airway equipment and practical considerations. I thank the presenters once more, and now it's time for questions. So if you have any question, you can raise up your hands, and you will be allowed to ask your question, while you can also input your questions on the chat box, and then the presenters will attempt the questions. Thank you. So we have questions from the chat box. First of all, I can't see anybody's hand up yet. So I think we'll just go straight to the ones on the chat box. First, I think most of the questions are addressed to the first presenter. The first question says, please explain sensitivity and specificity with respect to prediction of difficult airway. Dr. Tobola Olatunde, I hope you are still online.
Yes, I am, sir.
Okay, please note the questions.
Yes, I'm noting them. Good evening once again. The Dr. Kola Walege asks which test is the most sensitive and specific for prediction of difficult airway. Then Dr. Mustafa Bello asked which test is the most sensitive and specific for about the same question. So I'll take the two together. Sensitivity for a successful screening test, it has to have a good sensitivity, and the sensitivity are the true positives, the percentage of correctly identified patients with difficult airway. But we should note that the difficult airway, you have different things being assessed. You have difficult mask intubation, difficult mask ventilation being assessed. You have difficult direct laryngoscopy being assessed and difficult laryngoscopy being assessed. So, but to answer your question directly, the upper lip bite test is the most sensitive test for difficult direct laryngoscopy, and the modified Malampathy is the most sensitive for difficult intubation. So some authors, or many authors, have suggested combining these two tests so that you can have a higher percentage of people that really have the pathology that you are using your screening tests for. I hope I have managed to answer the question.
Okay.
One other thing that we should also note, sorry to put in, is that apart from using our screening test, you can see that the percentage, the screening, the sensitivity for Malampathy is 51%. Upper lip bite test is 63%. You still have about 49% other true negatives that are there. So 1 in 2 people, if you screen 1 in 2 people, you are just likely to get one. I'm just saying that, you know, plainly, you're likely to get one person that is a true negative. So it is good to individualize these patients. So don't just use your screening test. Take a history, examine the patient. If you need to do investigations to add to your screening test. This will give you a more holistic view of the patient and predict a difficult airway and help you to make an airway plan for the patient. Thank you.
All right. I can't see anybody's hand up. So I think you attempt the second question, while we'll see if anyone has any other question. The second question says, okay, you have attempted the questions on.
There's another question by Dr. Chima Naji. She asked for the difference between Malampathy, the original Malampathy, and the modified Malampathy. The original Malampathy has 3 classes, while the modified has 4 classes. So the original Malampathy is basically classes 2 and 3 combined to make 3 classes in the original Malampathy. And the class 1 connoted a relatively easy intubation, where the class 2 and 3 was easy, difficult, and, you know, the class 2 and 3 connoted a more difficult intubation. Then she also asked for identification of specificity, sensitivity, and specificity, positive predictive value, negative predictive value. I think I've explained that of sensitivity and specificity. Positive predictive value is the portion of patients, or the likelihood that a positive test will truly represent your outcome of interest, or the pathology or the situation that you are trying to evaluate for. So you classify someone as Malampathy 2. Was the intubation actually relatively easier, or it was more difficult? You know, so, and the negative is the proportion of people, or those with a negative result, who do not have the outcome of interest, or the disease, or what you're trying to assess for. So these are the answers.
Okay, thank you for those answers. I think there's still one more question for you. It says you should clarify on tests of mouth opening.
Okay, yes.
You mentioned either the examiner or the patient can do.
Okay, yeah, doctor. Okay, yes. On the mouth opening, what is most important? Because when we, whether to use the operator's fingers or the patient's fingers, what is important is for you to, your three fingers, what is the length or the breadth of your three fingers? For some people's three fingers might be even more than 6, some might be less than 6. So, but if you know the measurement of your fingers, you can use your three fingers. But if we want to be more objective, you can just get a ruler and measure the entire incisor or the mouth opening, the alveolar margins from one alveolar to the other, and measure. That is the most objective. But if you can always, assume with, if you know the measurement, the breadth of your fingers, you can use your fingers to estimate the mouth opening. So whether, well, I would say the operator's fingers, because it's more likely you know the breadth of your fingers than that of the patient's. So it's better if you know the breadth of your fingers, use your fingers. If you don't, get a ruler and measure the mouth opening.
All right. I think you made a fair attempt at answering those questions. I think the next questions are for Dr. Ibrahim. It says, what are the types of laryngoscope blade, handle, and indications?
Okay, thank you. So is the question, because what are the types of laryngoscope blade handle? So is it asking about the handle or the blades?
That was the question. That's just how the person wrote it. It says, what are the types of laryngoscope blade, handle, and indications? I didn't understand what.
Okay, so for the handles, there are different types of handles. We have, the blades. We have the cuff blade, which is the Macintosh, and then we have the straight blade. So like I said earlier, the choice depends on the patient's and then the provider's preference. But however, the straight blade is recommended for use in the pediatric patients because of the size of the epiglottis, which is large. And then unlike the cuff blade, that usually the tip sit at the vallecula, but with the straight blade now, it goes anterior to the epiglottis, thereby exposing the glottis. So it is recommended for use in pediatric patients. Then for the Macintosh, can be used in other patients, depending on what is available and then the preference of the provider. Then the other type of blade is the McCoy. McCoy usually is used in patients with anticipated difficulty, or in patients that maybe in their first attempt at laryngoscopy, the Cormac and Lehane view was 3 or 4. So you can, with the use of the McCoy, it can improve the Cormac and Lehane view. So, and for the handles, we have the short handle and then the standard handle. The short handle is usually recommended in individuals that have limited neck movement, or in those patients that are obese with large breasts. Initial, and then this can be used with with the polio blade, which can improve the view. Initially, the polio was actually designed for intubation of patients that are encased in the iron lungs, but later it was discovered to be useful in patients in such category of patients, example those with large breasts or those with limited neck movement. Thank you.
All right. Thank you for your answer. Somebody's hands were up initially, but the person has brought down the hand. The other question for you, Dr. Ibrahim, is says that we always talk about unavailability of equipment in our environment. Is it not time we invest in our practice than waiting for others to do that for us? I just want to make some comments on that.
Yes, I think it is about time that we start looking into how we can improve our practice with the with the provision of equipment, and that can be done in several ways, like our present, what we are witnessing through the Society of Specialists in Airway Management in collaboration with the Project Cure. We have recently, some hospitals have received donation of video laryngoscope. And this is a way that can enhance availability of equipment. So we have to look for collaboration with international donors and the rest, and also the manufacturers of such equipment. So, but very soon, I think we can reach there.
Yes, very soon we can reach there. Okay, Dr. Adesiyo Aderonke asks, says, thank you for your extensive presentation, Dr. Salim Abdullahi. Can you shed light on equipment for front of neck access, especially considering that we may encounter can't intubate, can't ventilate situations?
Okay, all right. Thank you for that question, my President. In the front of neck access, what the equipment that are required, we need a bougie, we need a size 10 surgical blade mounted on the scalpel, and then a size 6 cuffed endotracheal tube. So what we need to do when you encounter the can't intubate, can't ventilate situation, just get the blade, the size 10 blade mounted on the scalpel. So identify the cricothyroid membrane, and then with the sharp edge of the blade facing with the provider standing on the right side of the patient, the sharp edge will be facing the provider, and then you make a staff puncture on the cricothyroid membrane, and then rotate the scalpel 90 degrees. Now with the sharp edge to be facing toward the patient's leg. Then you introduce the bougie, remove the scalpel, then you rev the endotracheal tube over the bougie, and then inflate the cup and remove the bougie. And then that will serve as the surgical airway for the patient. So from there, decision can be taken whether to proceed with this procedure or wake the patient, depending on the urgency of the surgery. Thank you.
Thank you, Dr. Ibrahim, for those answers. I think the next question is for Dr. Tobola. He says, what is the Nigerian guideline for managing difficult airway? Dr. Tobola, want to make an attempt? Or Dr. Ibrahim?
Okay, sir. I'm not aware of any Nigerian guideline. Or there's, well, not published though. I'm not aware of any published Nigerian guideline.
Okay.
Okay, yes.
That of the Difficult Airway Society and American Association of Anesthesiologists.
Yes, in some, as some we are working toward that, we have a standing committee on local airway guidelines. So in the nearest future, we are going to release airway management guidelines.
Okay.
Yeah.
So we should be expecting the guidelines very soon.
Yes. Yes.
Okay. You are the Secretary General of SAM. So Abraham is raising up his hand. So Abraham, can you unmute yourself and ask your question, sir?
Yeah, good day, everyone. I just want to throw in a quick comment. Excellent presentation, by the way. I'm an ENT surgeon, actually. I'm not an anesthetist or anesthesiologist. I just want to throw in the fact that it's probably worth mentioning that if you anticipate a difficult airway, there's a role for a team approach. Perhaps, for example, getting a second colleague, anesthesiologist colleague, to be with you, or the most experienced anesthesiologist around, or even we're available, an ENT surgeon, to help you with the provision of a surgical airway. So it's not a solo approach in difficult airway. I just wanted to throw that in. Thank you very much.
Thank you.
Thank you for that wonderful contribution. Dr. Brian, you want to make comments on that? Okay. I think we'll move on to the next question. Can you hear me?
Yes.
Okay.
Yeah.
So the next question says, what is the difference between tracheostomy and cricothyroidotomy? What is the difference between tracheostomy and cricothyroidotomy? Dr. Tobola, I think that should be for you.
Okay, so a tracheostomy is done at a much lower level in the trachea. But a cricothyroidotomy is it's an emergency access. It's done through the cricothyroid membrane. So you can either do a scalpel cricothyroidotomy where you use a scalpel to jab and twist past your bougie and railroad your tube, or there are prepared devices. There's one called a quick track that has a trocar loaded on the tube. So the trocar is sharp, so you just push it through you don't push it all the way, just push it through the cricothyroid membrane. Once you are in, you remove the trocar, you push it down, you inflate the cuff, and cricothyroidotomy is what anesthetists do, that is part of our guidelines for airway management. And a tracheostomy is a more definitive type of airway for long-term access done by the ear, nose, and throat surgeons.
Okay.
Thank you.
All right. Okay. So the next question goes to Dr. Abdullah. He says, which tube is called the RAE tube? Thank you.
Okay.
Which tube is called the RAE tube?
Okay, thank you for the question. The RAE tube is a preformed tube. The RAE is named after the three individuals that invented the tube. The R stands for Ray, the E for is it Arwin or the E Eldwin? But the Ray is just an acronym for the inventors of the tube. So it's a form of preformed tube.
Okay. So another question for you, Dr. Abdullah. It says, to the second presenter, thank you for the presentation. One, what is ambu aura gain and what are the benefits of using it? Then the second question has to do with the Nigerian guidelines. I think we've answered that. Okay. So yes, what is ambu aura gain and what are the benefits of using it?
Okay. The ambu aura gain is a third generation supraglottic airway device. And then the benefits using one is a disposable device, that is, it is single use. And then it is anatomically is I think the only anatomically cuffed supraglottic airway device that has an integrated gastric access. So it's just a modification of the second generation supraglottic airway devices. So it's shaped like the intubating LMA. But what differs it from the intubating LMA is that it has an incorporated gastric access. And also it can serve as a conduit for tracheal intubation, usually assisted by a flexible scope. So it can also serve as an intubating LMA. meaning the airway can be intubated through that, and then it provides a high seal pressure. So meaning it can be safely used in the obese patients.
Okay.
I think these are the little about the ambu or again.
Okay. All right. Thank you for those explanations. I think we'll just take one more question from Dr. Naji, whose hand is up. All right, Dr. Naji, please.
Okay, thank you very much and good evening, everyone. I actually just want to make a comment based on the first question I asked with regards to sensitivity and specificity. And in line with those possibly going for exam to have an idea about that. For example, we know that when you're subjecting a bedside airway test to some analysis, you want to know how specific or how sensitive the test truly is. And when you're talking about sensitivity, let's take, for instance, Mallampati scoring system, modified Mallampati scoring system. You're trying to use it to know whether you'll be able to intubate a patient. For you to actually really say that this the sensitivity level is high or the specificity is high, you have to equate it to another test in order for you to achieve that. For example, most of the available tests you use to really identify if an airway testing if an airway test is actually very sensitive, we have like the Comac-Lahain test. So for example, I have a patient I have actually assessed with modified Mallampati scoring system, and patient is Mallampati 1. And when I want to intubate the patient, I'm realizing that this patient is Comac-Lahain 4. It means that I have problem with the sensitivity of this test. That's how to actually really assess. And for the specificity, yes, that actually identified that these ones are truly negative. However, if I assess a patient with Mallampati scoring 3 and try to intubate, the Comac-Lahain is 1, it means there is fault, some level of faulty with the test. So it's not really that specific. So that's how to actually identify how sensitive and how specific an airway testing device, airway test truly is. So we have the Comac-Lahain, which you can use to equate to it. We also have the American Society of Anesthesiologists guideline, which states that for any patient you try to intubate up to 3 times and you don't succeed, it means this patient is actually, by a skilled anesthetist, it means that this patient is actually, patient actually have difficult airway. So if you equate it to the test you have used, irrespective of what you got, let's assume it's actually Mallampati 1, it means the sensitivity is not really okay. And that's where the positive prediction value and the negative prediction value comes into play.
All right. Thank you, Dr. Naji, for that clarification. I'm afraid that these are the contributions and questions we can take at this moment. I want to thank the presenters once more, Dr. Tobowale, Dr. Towobola, apologies, Olatunji, Senior Registrar Department of Anesthesia from LASUT, Ikeja, for the first presentation, and Dr. Ibrahim Salim Abdullahi from the Department of Anesthesia in ATBUTH, College of Medical Sciences, Bauchi. I want to thank you immensely for your presentations. I want to hand over to the Secretary of the Education Committee to go ahead with the rest of the program. Thank you.
Thank you very much, Dr. Agbo, for moderating this session. We also want to once again thank Dr. Olatunde and Dr. Abdullahi. At this juncture, I want to invite the President of the Nigerian Society of Anesthetists, Dr. Briggs, to say some words to us. Ma, you have the floor, Ma.
Yes, thank you very much. You'll agree with me that today has been a very exhaustive session. And no doubt, this is a very desirable topic that cuts across all our various practices in our different specialties. And therefore, no wonder we had an attendance of about 228 the last time I checked on it. So we want to thank every one of you for being here today. And like I posted on the platform, our colleagues from various parts of Africa, Dr. Eva Hansels, you're most welcome. Faculty Chair, I saw you here, former Faculty Chair, Dr. Israel Kolawole. Thank you for being with us. Thank you, Professor Faponle. We're happy to have you as our senior colleagues and elders here. I also saw Professor Babatunde Oshimaike. Thank you so very much. I want to specially thank from SAM present here, members from ICCN, members from SON. I'm very happy for this collaboration, which we have started, and I pray we keep it up, even with you also, inviting us from your side. Sacrificing to be part of these webinars at no cost. NSA is very grateful to you all, and to all you members present, thank you, for taking out time for this. I want to just remind us that please, we should continue to make ourselves relevant and remember all the various events that are lined up for us this year. We have our national events, the Society of Study of Pain, the Intensive and Critical Care Society conference taking place in Port Harcourt, SON conference also, and even SAM conference. So let's all prepare ourselves to be part of this and make ourselves relevant. Of course, international conferences that are on board, please, you have to prepare in every manner. We have the ICCN conference this year in Istanbul. We also have the World Congress of Anesthetists Conference coming in Singapore next year, 2024, and the All Africa Anesthesia Conference in South Africa in 2024 also. So having said this, I want to thank you all. I want to ask that please, as has been posted by the PRO, be faithful with your dues, because that is the engine that we are using to run this webinar and meet with your needs. I want to thank Dr. Ngbemena for the suggestion he made about our own local solutions, and by inference, thank SAM for what they have done. And also, I want to ask that please don't hesitate, Dr. Ngbemena. I hope you are still on board. If you have any other suggestions for any area at all, in our various specialties.
Yes, I'm on board. I'm on board from the village.
Yes, Dr. Ngbemena, yes. So make your suggestions to the relevant societies for local solutions that can be brought up, like Sam has done. And we also know that some other people have made some, discoveries, inventions. I remember one time, Brigadier General Ovaji, he made an invention for blood salvage. And we also have our own Professor Gan, who made an invention for epidural anesthesia. So you are very correct. We should do more of that and, get them working. So thank you to everyone. Without wasting our time, you'll agree with me, this session has been extensive, but it is a needful one. And I want to also say to our various students, candidates for exams, that with all this, you have no excuse really. Anyhow it comes to you in the exams, you should be able to perform well. So go back, cross the I's, dot the T's, cross the T's, dot the I's, and get yourself prepared for anything that comes in this area. And please, our webinars are always posted to our YouTube. Go to our YouTube, subscribe, and get this valuable materials for yourself. So I'll hand over to the PRO for any other advertisement that is necessary. And then I want to tell all of you, thank you so very much. Have a lovely weekend, and then keep up yourselves. Thank you. Dr. Oshele, please.
Good evening, Ma, and good evening, everyone. Thank you. Just like the president has said, we want to thank those who have paid their dues for this 2023. And we are begging others to do same too, to pay these dues, because this is what we use in running our activities and in giving us this webinar at no cost. And all our presentations, all the recordings will be uploaded on our YouTube channel, Nigerian Society of Anesthetists. Just go to YouTube, search for it, and subscribe, and then put on your notifications. And once our videos are uploaded, you'll be able to watch them. Thank you very much, and God bless you all.